Hello and welcome to today's WEDI webinar, Claims 101. Thank you for joining today's webinar. And before we get started, I just have a few administrative details to go over. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. So at the end of the presentation, there will be a Q&A session. So in your GoToMeeting control panel, please type your questions or comments into the field and hit enter. And we will be addressing those questions and comments after the presentation, but feel free to ask your questions along the way. Just make sure you include enough context information if it's about a certain thing in the presentation so we know what you're talking about. Also, the slide deck along with the link to the recorded presentation will be emailed to all registrants following the live webinar. Now, without any further ado, I'd like to go ahead and hand it over to today's speakers. They are also the co-chairs for our claims subwork group here at WEDI. So thank you very much for your participation. And co-chairs, it's all yours.
Great, thanks, Sam. Rose, would you like to do the introductions, or shall we introduce ourselves first?
We can introduce ourselves, and I'll just get it going then. This is Rose Hodges, and I work at Aetna as the 837 subject matter expert.
Okay, Chris.
Okay, this is Chris Mushong. I work for Coons Lean Associates. We do custom software development and program management in the Midwest United States.
And Stanley Knockamson. I am the principal at Knockamson Advisors and a former CMS employee who worked on the HIPAA regulations back in the 2000s.
I think, Chris, you're gonna kick us off.
So here's the typical disclaimer. Presentations are intended for educational purposes only and do not replace independent professional judgment. Statements of fact and opinions expressed are those of the participants individually, and unless expressly stated to the contrary, are not the opinion or position of the Work Group for Electronic Data Interchange, its co-sponsors, or its committees. The Work Group for Electronic Data Interchange does not endorse or approve and assumes no responsibility for the content, accuracy, or completeness of the information presented. Am I able to move to the next slide, or? Next slide.
Stanley, are you driving? Stanley, are you driving?
Here we go. Yep. Okay, so what we set out to do. Oh, we're back. All right, we need to go forward one slide, please. There we go. All right, so we spent some time and recrafted our charter, and we thought about what we were really setting out to do as a sub-work group. This group's intention is to gather individuals knowledgeable with the electronic claim transaction and the business processes involved. With participation from individuals within the industry, we intend to educate those concerned with revenue cycle activities. And we also collaborate and share best practices and solutions to common claim submission problems. Okay, next slide.
You got it, Chris, because it's up on my screen.
Okay, this is how we accomplish our intentions. We are always staying abreast of the upcoming changes to the next version of the standard transaction. We are understanding and illustrating how the transaction is used in the industry with white papers and presentations for industry solutions. And we have completed surveys and issue briefs and webinars as well.
All right, I think as this is Stanley and this is my spot, correct?
Yes.
So let's talk about what a claim is, and that's the focus of all our work. It is generally understood as the way that a healthcare provider sends information to a health plan describing the services that are provided to their patients and requesting payments or reporting the services when no payments expected if there is a managed care or a capitation arrangement. Basically, the bill from the provider to the health plan to get paid. Now, under the HIPAA regulations, a claim is defined specifically as, with the equivalent encounter information, it's a request to obtain payment and the necessary accompanying information from a healthcare provider to a health plan for healthcare. And if there is no direct claim because the reimbursement contract is based on a mechanism other than the charges or reimbursement rates for specific services, the transaction is the transmission of encounter information for the purpose of reporting healthcare. And this is important under HIPAA because this is the definition of the electronic transaction that gets standardized for the industry to do the claim transaction. Now, as health insurance became more prevalent in the US, certainly back in the early times, there was direct payments from individuals to their providers. There was no need for this intermediary, but health insurance became more prevalent. So payments for medical services were shifted from their direct payments from patients to payments by insurance companies to providers. The paper billing forms had been developed by individual companies and the Medicare program to provide the necessary information to properly pay the claim. And of course, these were individual forms that were done for the purposes of each company, although there might be some similarities. Obviously, there were differences from company to company. And in fact, in the mid-20th century, each state had its own type of billing form. There are two general types of bills or two general types of claims that are most prevalent in the industry. It's the hospital or inpatient billing form. That was developed by the National Uniform Billing Committee. New York State used the UBF-1 form, for instance, but the National Uniform Billing Committee developed the UB-82 form, which was released in 1982, hence the name UB-82, after 7 years of research and debate. Now, as the industry matured and after gathering feedback from each state, the NUBC developed a revised UB-92 form, and subsequently the UB-0 form, again, these are paper forms, which has been the official billing form for the Centers for Medicare and Medicaid Services, CMS, since 2007. So that's our official paper billing form. On the physician or the outpatient side, back in 1958, a couple of organizations, health plan organizations, the HIA and physician organizations, the AMA, attempted to standardize the insurance claim form, eventually known as the COMB-1 or the attending physician statement. In 1975, AMA approved the universal claim form, referred to as the HCFA 1500, the abbreviation for the Healthcare Financing Administration. AMA then joined forces with the CMS and other payer organizations, known as the Universal Claim Task Force, to standardize and promote the use of this universal health care form. In 1990, the HCFA 1500 was revised and printed in red ink, allowing for optical scanning of claims, the beginning of some sort of electronic processing of claims. All services for Medicare patients from physicians and suppliers, except for ambulances, which have their own form, reported after May 1st, 1992, had to be billed on this scannable HCFA 1500 form. Just for history's sake, HCFA was the organization that later became CMS. So the HCFA 1500 and the CMS 1500 are in essence the same form. In the mid-1990s, the Uniform Claim Task Force was replaced by the National Uniform Claims Committee, whose goal was to develop the data set, a standardized data set for use in the electronic environment, but applicable to and consistent with evolving paper claim form standards. Now here we go to the beginning of electronic transactions. Beginning in the late 1980s, although the electronic transactions were scattered among different companies and providers, Medicare and most of the other insurance companies began to encourage the submission of claims electronically. While the contact was based largely on the standard paper forms, it clearly varied from plan to plan. And the formats also varied from plan to plan, which placed a lot of burden on providers and any type of vendors who were developing the software to create and transmit claims, and also on the health plan side to process those claims. Despite industry efforts, there was no overall agreement that was reached on the format and content of electronic claims. So the industry sort of went to Congress in 1996. Our HIPAA legislation was passed that required the Secretary of Health and Human Services to adopt national standard electronic formats for claims and other transactions, and those standard formats were mandated for use by providers and health insurance plans that used electronic transactions. In August of 2000, the department adopted our first set of standards for electronic transactions, the ASC X12 version 4010. Those standards were required for use initially in October 2002, but a extension was granted for an additional year. So actually, October 2003 was the final official implementation date for this first set of electronic standards. In January of 2009, the department adopted updated versions of the standards, the ASC X12 version 5010, requiring adoption by January 1st, 2012. And that version of the electronic transactions is still required as of now. The X12 organization is in the process of updating their standards. However, no specific date for the next adoption has been announced. So here's how claims basically work in relation to other transactions. As a patient initially makes contact with a provider organization, that organization tends to verify the eligibility and benefits for that individual from the individual's health plan. There's an electronic transaction that allows for the inquiry and response on eligibility and benefits. And if the particular service needs a prior authorization before it's provided, that can also be done electronically and is sort of the next step in the cycle. The third step is, once the service has been performed, is the claim or the request for payment for that service, along with the necessary information as we previously have defined it. Once that claim is submitted, the provider has the opportunity to inquire of the health plan what the status of the processing of that claim is, if it's been processed, if any other additional information is needed. A claim attachment can be provided from the provider to the health plan to help with the processing of that claim, again, if necessary. And then once the claim is processed, a remittance advice and payment is provided back to the provider. That remittance advice may pay in full, may only be a partial payment, or maybe a denial, with information back to the provider as to why and how the claim was paid partially or denied. And for each of the electronic transactions that are sent between partners, electronic acknowledgements can be sent that says a particular claim file or a transaction file was received, or an individual transaction was received. Therefore, the sender knows that the receiver got it. So again, here we go. The eligibility request goes from the provider to the payer. Then through will send something back to the provider. A prior authorization may be necessary. The provider sends the claim and acknowledgement from the payer. A provider can send a claim status request and get information back from the payer, who will then eventually send the claim status response and the remittance advice and payment. So that's basically the transaction flow. And Rose, I believe we can turn it over to you now to discuss the business purpose of the transactions.
Sure. Thanks, Stanley. Okay. I will tell you when to turn the slide, okay? All right. We're just going to go through some of the transaction basics. The following ASC, and ASC is a short term that's used to say the Accredited Standards Committee, which is X12. Claim transactions that were named as the standards for the submission of electronic healthcare claims / encounter information from the provider to the payer, or via an intermediary such as a billing service, a vendor, or a clearinghouse to the healthcare payer. So we have three different 837s that we're going to be speaking about, and that would be the healthcare claim professional, institutional, professional, which is also known in the industry as an 837P. Institutional is also known as an 837I, and the healthcare claim dental, which is known as the 837D. So 837 is a generic term when referring to electronic claim transactions. That might be either one or a combination of all the three. So with that, just going through what each type of 837 would be used for the 837P, which is the professional format, physicians, suppliers, and other non-institutional providers would use it for both outpatient and inpatient services. The 837I, which is the institutional format, institutional providers such as hospitals, long-term care facilities would use that transaction for both outpatient and inpatient services. And the 837D, the dental format, would be used for dentists and dental care providers. Next slide. And just some benefits for using the 837 are listed here, which would be it would reduce the administrative burden and costs to both the provider and the payer. More efficient processing of claims, which you would have no loss claims using an electronic process because manual handling is eliminated for the paper claims, and the ability to electronically track files and claims. There would be a substantial amount of decreased time for both the providers and the members receiving their reimbursement. And there's much more data submission consistency because with the 837, you have consistent data fields that are always required to be sent by the provider to the payer. Move on to the next slide. Some examples of when an 837 is used outside of a typical fee-for-service claim submission are listed here. And just to run through them, payer-to-payer for coordination of benefits, also known as COB. And an example of that would be the Medicare Direct or Medicare Crossover process between the Medicare administrators and the commercial payers, where the claim initially goes to the Medicare administrator and they do their processing and send the claim over for coordination of benefits to the commercial payer. The next one would be payer-to-payer for subrogation of benefits. An example of that would be the Medicaid state agencies, where they're recouping the money paid to providers for patients who had private insurance. There's also sending data to regulatory agencies that monitor various aspects of healthcare services within the industry. And examples of that would be sending the claim or encounter data for Medicare Advantage members over to CMS, and sending claim and encounter data to the Medicaid state agencies. And the last item on the slide would be alternative payment models. An example of that would be delegation and capitation, where the 837 is used to provide information on the services performed on a patient and are sent on to the payer as an encounter. And just to highlight that, we just completed a white paper that may be released pretty shortly on Encounter business models, and a lot of information would be found in there about the alternative payment models, and also sending data to regulatory agencies. So Chris is going to go over white papers at the end of the presentation. You can go on to the next slide. High-level transaction structure. Just briefly, a high-level description of the 837 information included is in a single healthcare encounter between a patient and provider. For the providers, we would have the billing, potentially the rendering. That's not always required. Attending is not always required, and referring is not always required, but the billing is always required to be sent. A subscriber and their health insurance plan information, where the patient was treated, patient demographics such as their birth date and their gender, the patient diagnosis that was found by the provider, the services and dates of services, charge amounts, and if there was coordination of benefits with a previous payer, all the coordination of benefits information would be listed in there for the next payer to use to complete adjudication. Next slide. Continuing on the high-level transaction structure. At a high level, the 837 file structure includes loops in the following categories. At the header, which would be the beginning of the file, and then we have the beginning of the claim batch. Following, we have the billing provider detail. Then we have the subscriber detail and the patient detail when it's different than that of the subscriber. We would then have the claim detail, and then the end of the claim batch and the end of the trailer, which would be ending trailer, which would be the end of the file. Obviously, that's very high level. There's a whole bunch of information in between other than that, but that's a high level. You can move on to the next slide. Just giving some additional information on the file structure. Subscribers and patients can have multiple claims under a single billing provider, and you can also have multiple different subscribers and patients with claims that can be under one billing provider. So an example of the first bulleted item, which was a subscriber and patient or patient with multiple claims under a billing provider, is listed on the slide. You would have the beginning of the file, which would be the header, and the beginning of the claim batch, then the billing provider detail, subscriber detail, patient detail if it's different than the subscriber. Then you see multiple claims, and then the end of the claim batch and the ending trailer, end of the file. Next slide. Just depicts the multiple different subscriber/patients with claims under the same billing provider. You would have the header, which is the beginning of the file, beginning of the claim batch, billing provider. You see the subscriber and patient if it's necessary to send a patient, and then the claims. And then you'd see the next subscriber under that same billing provider with their claim. And then you see the end of the claim batch and the end trailer, which is the end of the file. Next slide. Now, this slide is just speaking about claim level versus service line information. There could be fields sent at the claim level that would apply towards the entire claim unless there is information sent at the service line level, which would override the claim level information. An example of this would be in the 837, you can have a rendering provider at the claim level, but also one at the service line level. So if you have a rendering provider at the claim level and the service line level, the service line level rendering provider was the one that actually performed the service for that particular service line. And the claim level rendering provider would have been used or performed the services for the other service lines that don't have a specific other rendering provider listed. The following data can only be sent at the claim level. Therefore, those values would apply to the entire claim. So we have the submitter, receiver, billing provider, pay-to provider, pay-to plan, payer, subscriber, and patient. So all of that data would apply to the entire claim because there's no service line information for those particular fields. Next slide. On this slide, we're just listing some of the data values that can be sent at both the claim and service line level. And as I stated before, I gave you rendering provider as an example of this situation. You could also have the service facility location, referring provider, prior authorization number, and referral number sent at both the claim and the service line level. And just as a reminder, if they're sent at both places, the service line overrides the claim level for that particular service line. Next slide. Here's another data submission scenario. We would have a billing provider address versus pay-to address. So when we have a billing provider address, it must always be a physical address and never be a PO box or a lockbox. But some providers have a physical address, but they want their payments sent someplace else, such as a PO box or a lockbox, or maybe even another physical address. So you have a pay-to address, and that must be used when the billing provider has an alternate address for their correspondence or payments. Next slide. Another data submission scenario is listed here, and that is dealing with when a subscriber is needed or when a patient is needed on a claim. So a subscriber is always needed on the claim, but we wanted to point out when a patient is needed more than the subscriber. So a subscriber is always needed, and the second bullet under subscriber, if the patient is uniquely identified by their member ID number, then the patient is the subscriber and no patient information is sent in the claim. On the right side of the slide, we're going over when a patient is needed in the claim. If the patient is not the subscriber and cannot be uniquely identified by their member ID number, then both the subscriber and patient information is sent in on the claim. Next slide. Another data submission scenario that's listed in the deck is for drug information. There are situations where you need to send a single drug billing, and the submission of drug services can be accomplished by sending the HCPCS or healthcare HCPCS, HCPCS stands for Healthcare Procedure Coding System, and that's the procedure code at the service line level. What you would want to do is send the associated NDC, that's National Drug Code, with the dosage at the same service line. Next slide. Drug information is continued here because there is situations where you need to send a compound drug. And there's drug components that are reported on separate service lines, and that would include the prescription number or link sequence number that's reported and assigned by the provider and is unique for the claim. And it's either used by the payer to identify, that doesn't really make sense there. It's used by the payer to identify all the components of the compound drug. Some additional notes related to compound drugs. They're used for unspecified drug HCPCS code. The submitter must also send a procedure description. The additional NDC code must be sent if mandated by federal or state regulations and when it could facilitate claim adjudication. Payers who require the NDC code to facilitate claim adjudication should note that in their respective companion guides, and providers should reach out to payers if they require clarification for when procedure code description is required to be sent. And it's important to note, as I said before, Chris is going to go over where white papers are stored. There is a comprehensive white paper that was sent out a few years ago on the submission of drug claims. And that's out on the WEDI site as well. Next slide. data submission scenarios is continued. We'll talk a little bit about COB, coordination of benefits claims. COB occurs when a patient has multiple healthcare insurance coverages, and the COB submission models supported follow. The most common one is the provider to the payer to the provider, and a high-level description of the flow follows. The provider sends the claim to the primary payer. The payer completes adjudication and sends the electronic remittance device, ERA, or explanation of benefits, which is also known as EOB. The ERA/EOB includes the previous payer's adjustments and payments, as well as other pertinent information. The provider sends the claim then to the secondary payer, including information about the primary payer, what the primary payer paid, and any adjustments and other pertinent information again. I just put a note there that the EDI claim can allow for 11 previous payers, which would be very highly unlikely that would ever occur. Probably 1 or 2 previous payers is most likely all you'll ever see. Next slide. For COB, we're just going to continue talking about another model, which I touched on briefly at the beginning of the presentation. We have provider to payer to payer. The most prevalent payer-to-payer COB model, again, is the Medicare crossover process between CMS and payers. And a high-level description of the crossover process includes the provider sending the claim to the primary payer, which is Medicare, and then Medicare completes adjudication and sends the provider's ERA and EOB. The ERA-EOB includes the previous payer's adjustments, and when applicable, a specific remit code when the claim is automatically crossed over to the secondary payer. And that's important to note because, you know, the payers don't want to receive duplicate claims, one from the provider who's sending it and one from the Medicare crossover vendor who's sending it directly to the payer. So the provider should take note of that remit code and not send the COB claim to the payer themselves. So when the crossover vendor sends the claim to the secondary payer, it includes information about the Medicare payer, the Medicare payer's payment adjustment amounts and payment amounts, and then the secondary payer completes adjudication and sends the provider an ERA and EOB. Next slide. Just touching on here the balancing of a claim. The total claim charge amount must always equal the total of the service line charge amounts. And I'm sure that, you know, there's a lot of validators that catch this type of unbalanced situation. For example, there's a very easy example listed here where the total charge amount is 100, service line 1 is 25, service line 2 is 75. So the service line total is 100, which matches the total charge amount of 100. Next slide. On balancing, we're going to continue talking about the COB scenario tied to balancing. So in COB scenarios, the previous payer claim amounts must equal the line level payment amounts minus the claim adjustment amount. So there's an example listed there where you have service line 1 charge amount of 70, service line 1 payment amount of 40, and service line 1 adjustment of 30. So the service line 1 charge amount was 70, which equals the service line 1 payment amount of 40 plus the service line 1 adjustment amount of 30. So that 40 and 30 is 70. So that balances. In the second service line, the charge amount 25, payment amount was 10, service line adjustment would be 15. So the service line 2, I made a mistake there, sorry. Charge amount is 25, which is 10 plus 15 on the payment amount plus the adjustment amount of 15. So that equals 25. Next slide. Another data submission scenario is property and casualty, also known as P&C. So the 837 healthcare claim can be submitted for property and casualty lines of business, such as workers' comp and auto. In workers' comp, the states regulate the electronic billing, which is e-bill/HIPAA transaction, with state-specific data requirements that are based on International Association of Industrial Accident Boards and Commissions, also known as IAIABC, the International Workers' Comp Regulatory and Standards Organization. And it's important to note that if you're interested in knowing anything more about property and casualty, which I'm not going to go into here, because there's a specific sub-work group for WEDI that works on educational material, and they're going to have their own webinar in the future. So notification for the PNC webinar will be sent out via the WEDI listserv. Next slide. I think that this is Chris's to take over.
Thank you, Rose. That was a lot of great information there.
Thanks.
So our finished work and our work in progress. Our finished work has taken forms of white papers, technical white papers, issue briefs, and webinars such as this. And they're all found on wedi.org under the Knowledge Center tab. And then under that, you go to white papers and issue briefs. And we've listed the URLs below for when you get the presentation electronically. You can just click on the link and it'll take you there. Some examples of our work include, as Rose mentioned earlier, a webinar on how to report the national drug codes within the transaction set. Some issue briefs that we put out were the 5010 changes that can be implemented now without fully upgrading, the billing provider and pay to address reporting, and strategies to minimize claims disruptions. Next slide, please. So this group in the last, I think, year plus, we've been working on a couple things. And what we put this in iMeet as well to kind of have a repository of our work in progress. We reviewed the proposed 70-30 changes and quantified the business impacts. The thinking here was we were trying to maybe put together maybe a paper down the road that would motivate the industry to adapt 70-30. So we wanted to create a list of some business advantages. One of the large advantages we came up with were that the 70-30 will have predetermination requests built into it. A medium level bottom line is we have to add the original claim creation date. And one of the small ones was there's an ability to apply prior authorization to specific service lines and not the entire claim. And we actually just finished our final draft of a white paper that's in the final stages of review that you can expect shortly. It's titled Understanding Encounters, Models, and Definitions. Okay, next slide. Is that the last one? Oh, we got one more. Okay. So this is how we all work together. We have conference calls, lively conference calls, every second and fourth Thursday of the month at 11 a.m. Eastern. The co-chairs are always available through email, and our emails are listed below. If anything comes up, if anyone asks you a question that you think the claim sub work group might know, just send us an email, and then that's a discussion starter for our sub work group. Okay, so that's all we have for our presentation. We'd like to open up the floor to question and answers. Sam, did we have any questions submitted yet?
Yep, we already have a couple. If anybody else has any questions, go ahead and submit them. We'll start off with the first one. Are any Medicare Advantage plans using the payer-provider model with Medicaid, similar to the Medicare Part AB coordination of benefits process?
Could you repeat that? I didn't quite catch the model there.
Are any Medicare Advantage plans using the payer-provider model with Medicaid?
Your payer provide. I'm not sure. Stanley, do you know? Or
No.
Chris even?
No, I don't know. We know that Medicare is a payer of last resort. Rose, does Aetna do a Medicare Advantage?
Yeah.
Do you have Medicare Advantage plans? So that might be something
Yeah.
that we could certainly find out to see if they're doing direct COB with Medicaid or requiring the provider to do it, right?
Yeah, I was wondering if Chris might know because he's I thought Chris was Medicaid.
I am. I'll have to do some research on this.
Yeah, I'll do it as well too.
Okay, the next
Okay,
question.
we can make that available.
Sorry,
Great. Are you guys ready?
Yeah, sorry, Sam. Go ahead.
Why is provider payer to payer COB not prevalent across the board, not just for Medicare crossover? Provider payer 1, provider payer 2 does not bring the full advantages of HIPAA administrative simplification to providers as they remain an integral and required part of the information flow from payer to payer.
Well, I can speak from an Aetna perspective that it is a pretty big part of our business model where most of our members and plan sponsors do have this type of a scenario set up. I'm not certain why it's not as prevalent throughout the industry. I would not be familiar with if there's any drawbacks for other payers that do not deploy the same type of thought process. You know, it's a very good. The crossover process is very good in that there's a lot of consistency in the information that is sent by the Medicare processors, and you know, there's very little issues with data that's received from the Medicare processors. So if it isn't very prevalent in the industry, I you know, other payers, I couldn't say why.
Yeah, this is Stanley. I think a lot of it has to do with the fact that the providers are probably more familiar with the secondary insurances that individuals have than the health plans themselves, and are probably in a better position to keep up with changes in the patient's health insurance. I think that's one item, and there are some questions about you know, the accuracy of the information and also tracking information, and who is in a better position to send the information and track it. Is it the provider or the payer? You know, given that it's the provider is the one that gets paid. You know, one consideration is the health plan is you know, doing their the individual or the provider a favor by forwarding it on, but you know, taking on the tracking is an additional burden for health plans. You have another question, Sam?
Yep. Will the 70/30 change for authorization use at line level enable multiple authorization codes to be included, unique codes to each service line?
I'd have to, unless Stanley, you know off the top of your head, I'd have to crack open the 70/30 to see what the changes are, or Chris.
No, it has not yet been finalized. We're very close to the point where the second public review period will be available, and I hate to you know, guarantee or make any statements about a document that should be published very shortly. So you'll want to look and see once X12 makes the 837 claim 7030 transaction available for public comment, take a look at that and see what the document says.
And comment accordingly if you need to.
That's the last question that has come in. If anybody has any more questions, feel free to submit them now or even follow up following the webinar, and I can send your question. Oh, we've got another one.
Good.
Provider to payer to provider to payer needs further discussion across the healthcare community. There appear to be some misperceptions based on the responses.
I think that's an excellent point, and that's certainly one of the topics perhaps that could be brought to our work group. I don't know who made the suggestion, but we'd certainly welcome you to join our work group and suggest that as a topic. And in a lot of these questions that you've raised, many of our work group members have specific expertise in particular areas and could answer individual questions. That's one of the benefits of the work group, where when we share information or share questions, we can get those questions answered very quickly. Although Rose and Chris are quite knowledgeable about the claim and operations, and I have some knowledge, we certainly don't know everything, but basically, if you've got a question, somebody on our work group, I'm sure, could answer that specific question. So we welcome you to join our group, join our listserv, and get answers to those types of questions, and also make those suggestions for further white papers that and efforts that we could explore. Rose or Chris, you have any comments?
No, I was just thinking the same, because I live in my own little world here, and I just had conversations with some claim ops people, and no one is raising any issues about COB, but I might not be talking to the right people. So like Stanley said, if there's certain areas that need discussion or an educational paper, please join our work group and raise them, and we'll see what we can do to fix any misconceptions in the industry about how COB actually works, or if there is issues with the submission of the data, we can try and address it with the white paper.
Those are some great comments. We have another question that came in. Do others experience issues with the rendering provider loop not having an address? Well,
I mean, the rendering provider, if there's a rendering provider and the data or the service was performed somewhere else, then you're supposed to be using the service facility location loop to identify the address. And I think there is a white paper out there about submission of the provider data and how it works with use cases. And I think Chris went over before where all the white papers are stored. I would suggest you take a look at that white paper, and if it doesn't answer your questions sufficiently, again, that's another area maybe we need to look at that white paper and together as a work group and just raise what your issues might be that we can address it.
Great comments. Are there any other, sorry, another question just came in. We are attempting to set up our outbound 837 IP through our clearinghouse. We are having a difficult time as if the provider is not set up to receive electronic claims. Clearinghouse is not able to print the claim from within the COB field. Any other health plan having this issue?
I haven't heard of that issue.
Sorry, my
Okay.
audio connection got dropped. I didn't hear, I heard some difficulty about setting something up with the clearinghouse, but I didn't hear all the details. Would you mind repeating that, Sam?
Sure. We are attempting to set up our outbound 837 through our clearinghouse. We are having a difficult time as if a provider is not set up to receive electronic claims. Clearinghouse is not able to print the claim from I'm thinking that's form with the COB fields. Any other health plan having this issue?
I guess I don't quite understand why the provider needs to receive electronic claims. I'm a little confused because the private providers are usually the ones that are sending electronic claims, unless you're saying that the provider is not able to receive the remittance advice. But Rose or Chris, did you understand that?
No, I'm with you, Stan. I was thinking maybe that it's meant to be an 835 instead of an 837. That's all I can think of.
In the provider to payer, back to provider to secondary payer, the provider sends the initial claim, hopefully electronically, to the payer, and then the first payer sends back an 835, correct? To the provider with the information. And then the provider uses the information on the 835 to submit the secondary claim to the second payer.
Mm-hmm.
So
correct.
So I don't know what they mean about the provider being unable to receive an electronic claim. And it could be an 835, and if the provider can't get the electronic remittance advice, I mean, I think that's first of all, it's an issue for the provider that you know, my general recommendation, my opinion, is that providers should have their billing systems updated enough to be able to participate in all of these electronic transactions. And if they have a billing system that can't receive and understand an 835, I think that's a bigger issue, especially if they're going to deal with a number of these coordination of benefits situations. So that would be something where you know, the clearinghouse and the provider ought to be working together on updating the provider system.
Thank you for the comments, co-chairs, and if that individual wants to follow up with any more information or questions, feel free to do so or contact me after the webinar, and I can pass on your questions or comments to the co-chairs. If there aren't any other questions or comments from the webinar right now, do you have any closing thoughts from our panelists?
I would say just join our work group, especially if you have some concerns about your EDI process, your EDI claim submission, receipt and submission process, and where you think that there's some educational information that might be needed.
Absolutely, and say just participation on the phone calls is great. We have a good exchange of information. You know, twice a month. You're not required to be on every phone call. We welcome greater participation and you know, folks that are willing to help write and edit papers, but that's not necessary. If you'd like to just listen in, give suggestions, ask questions, we'd be delighted to have you as part of our work group.
Yeah, just to follow up on that, there are a lot of people that just call in and then put us on mute, and so they're working while they are listening, and when a buzzword comes up, then they might chime in out of nowhere, you know, and say they can help, or they know of someone that can help with a certain issue. So if you call in, you're not obligated to do anything but except just listen, and so please don't hesitate. Thank you.
And thanks, Sam, for facilitating. And I think we're good to go.
Thank you very much. I hope everybody enjoyed this fantastic webinar. I'll be following up with the slide deck and the link to the recorded webinar. Feel free, if you have any questions or comments or need to know how to join the claims work group, please just reach out to me, sholvey@weedy.org, and I'll be happy to help you out. Thank you again to everybody for participating today, and we look forward to seeing you hopefully actually on our next claims sub-work group call, which will be this Thursday from 11 to 12 Eastern Time. So thanks again for joining, and we look forward to having you join the work group.